Good morning, good afternoon, and good evening. And thanks to all of you for joining us today for this Path Live Forum, where we will be discussing new tools for Plasmodium vivax malaria for treatment, as well as the point of care testing for G6PD deficiency. And in the new tools, we'll be discussing the single dose tafenoquine for the treatment of relapses in P5X malaria. And we'll also learn about the country experiences for the same, and as well as global insights on the practical steps needed to ensure new innovations so that they can reach the people who need them most, and what can be the challenges and bottlenecks there. We are grateful to GSK for their support in making this session possible. My name is Dr. Neena Valecha, and I'm chair of Vivex Working Group of Asia Pacific Malaria Elimination Network, APMEN, and I'm delighted to be moderating today's conversation. Now, we'll be going over a few logistics first. And since we would like it to be an interactive session, please share your questions and comments with us by submitting them in the chat or Q&A box at any time throughout the discussion or presentations. And I'll try to monitor the questions, and we'll take them after all the presentations. And it will be good if you can mention to whom the question is addressed. It will be easier for the speakers to address them. And we are also pleased to offer interpretation in Portuguese for today's forum, and to follow in either English or in Portuguese. You can select the channel of your preferred language using the interpretation button in the tool, which is in the toolbar. And finally, I would like to inform you that the call is being, this meeting and webinar is being recorded so that we can use it and distribute for those who are unable to attend. And I can see about more than 70 at the moment, and still more are joining, participants from all over the world. And of course, we had invited government representatives, community organizations, NGOs, donors, as well as private sector partners. And thank you all for joining this forum. And we can have a discussion on a very important, critical new tool for vivax malaria. Now, let me now take this opportunity to introduce our panelists and experts. We have with us Emily Gerth-Guyette, Research and Development Officer, Diagnostics from PATH. We have Dr. Marcus Lacerda, who is a public health specialist at Fiocruz, Amazonia, and he's a medical researcher. Dr. Peter Olimis is Technical Lead, Malaria Case Management, Malaria and Neglected Tropical Diseases Department, WHO, Geneva. We also have with us Professor Kamala Timmer, Senior Principal Research Fellow, Menzies School of Health Research. And I thank all the panelists and experts for taking time to join this webinar. I know they are busy. So now let us start the presentations and the discussions. So let me first request Emily just to take us through the opportunities we have with new diagnostic tools for vivax malaria. Over to you, Emily.
Thank you so much, Neena. Really happy to be here today. I'm going to speak on behalf of the whole diagnostics team here at PATH and Gonzalo Domingo, and I have a few slides to guide us through our discussion. So maybe just to first, talk a little bit about, what is vivax, and we know that vivax can really present a unique challenge, in that the infection can hide in the liver and cause these, as you can see in this image here, these repeated relapses. And these relapses contribute to increased morbidity over time and can have this cumulative effect, causing people to feel unwell, miss work, etc. Vivax also has a huge global burden. So it affects more than 9 million people, according to the last World Malaria Report, with cases concentrated in countries like Ethiopia and India, quite a few in the Eastern Mediterranean region. So yeah, so Vivax is a unique challenge for diagnosis. Next slide, please. In order to be able to treat and one day eliminate Vivax, we do need to be able to diagnose it better. And so we can identify the blood stage of Vivax relatively easily, or at least using traditional methods, microscopies and RDTs, commonly used to diagnose malaria. However, we know that the lower parasite density associated with Vivax infections can mean that using these traditional methods, a lot of cases are and can be missed. And then as for the liver stage, this is really where it gets challenging for diagnostics, because these parasites are actually invisible to those traditional methods, can't be diagnosed using microscopy and RDTs. And we know that these liver stage infections are a huge proportion of the Vivax cases. And these are those recurring or relapsing cases that contribute to onward transmission, present a persistent challenge for elimination, and increase morbidity. And then in terms of treatment, we need two drugs, one for the blood stage and another for the liver stage. And the other panelists on this discussion will talk in more detail about those drugs in subsequent presentations. But I think importantly for diagnostics, neither of these treatments should really be given to people with G6PD deficiency, which is a common genetic condition in certain parts of the world. And so we know that we need to be able to screen for G6PD deficiency at the same time that we identify and try to treat those cases. And the reason that they should be screened is that there is a risk otherwise of a contraindication called acute hemolysis, which can be really dangerous for patients. Next slide, please. So in terms of new diagnostic tools that we're excited about, we wanted to highlight two here today. The first on the left side of this slide, as you can see, are next generation RDTs. And these RDTs have better sensitivity for both Vivax and falciparum. As you can see on the table here, we have looked at the predicted sensitivity of these tests, these next generation RDTs, compared to the current RDTs in both symptomatic or febrile populations and asymptomatic populations. And so not only will these tests help us better diagnose Vivax in sick people when people show up at health facilities and are seeking care, but they also have improved sensitivity for asymptomatic cases. And those asymptomatic cases are going to be contributing to onward transmission and really kind of harboring that parasite reservoir. And being able to identify those cases can make a really big difference when we're talking about control and elimination goals. And the second tool we wanted to highlight here, PV Serotat, PV Serological Test and Treat. This is a test that can really help us identify people who have been recently infected with Vivax and still possess the relevant serological markers. And so this is a test that looks at select antigens combined that to really identify people who have been infected within the previous nine months at an 80% sensitivity and specificity. And so with this test, that really opens up a lot of options for better surveillance, potentially more targeted treatment of that parasite reservoir through focal treatment or other types of mass drug administration. And I think just ultimately gives malaria control programs another tool to use as they think about how to identify cases in their communities. Next slide. And then finally, is the G6PD testing at the point of care. And so G6PD testing at the point of care has really been sort of the missing piece of the puzzle in some ways. And it's helped make some of these vivax treatments safer and build confidence in the drugs that we know can work. And so there's been quite a lot of evidence generated recently on how this tool can be integrated into malaria case management in lots of different settings. Dr. Lacerda will talk about one shortly, and also Professor Kamala. So this test highlighted here, the standard G6PD test, along with a few other candidate tests that are in the pipeline, are really able to take measurement of the G6PD enzyme, as a test that could only be done in a laboratory, and bring that to the field, to patients where they're seeking care and needing treatment. It's really been a critical piece of expanding access to radical cure. And it helps inform who can get the drugs for that liver stage infection, classifying people based on their potential risk for hemolysis, that sort of dangerous side effect of some of the liver stage drugs. As you can see on the chart in the bottom here, males and females who get a test result in the higher range, in that green level, can safely receive radical cure treatment, whereas those who test in the red areas should not. And the test has been particularly impactful for treating females, some of whom measure in that yellow range, that G6PD intermediate range. And for those women, they may be eligible for certain treatment regimens, but not others. And this just gives a more accurate picture of their treatment eligibility. Next slide. Yeah, so in summary, these are some of the new diagnostic tools that we're feeling hopeful about for the detection of people who have P-vivax or infected with P-vivax, and point of care G6PD tests really open up this possibility for broader access to the best treatment options, even in the most remote settings. I think an important piece of it is to make sure that these products can be effectively adopted and used in the settings where they're needed most. And I think just to kind of drive that point home, wanted to share, we talk a lot about how important G6PD classification is to ensure that people are getting the right treatment. But as you can see from the bar graph, and I'm sorry, the colors seem to have translated a little bit on this version, but ultimately, I think what we're trying to show is that the majority of cases that we're missing are just people who are not getting tested at all. So whether or not they're not seeking care, or they're sort of asymptomatic, and so we're unable to identify them through traditional methods. I think it'll be, continuing to be really important to strengthen overall health systems, really making sure malaria control programs have the tools they need to identify cases, encourage more case finding efforts, and supporting malaria control programs to continue to prioritize vivax alongside some of the other challenges they have. So that's my last slide. I'll pass it back to you, Nina. Thank you.
Thank you. Thank you, Emily. I mean, really, you summarized it so well. And of course, we know this testing of G6PD and point of care, availability of point of care test is so critical when we are talking about single dose cure, which is, of course, important when we are talking about elimination of malaria and the relapses. But, the information related to relapsing in countries, I mean, there are many gaps. But in addition, the fact you highlighted it, even the diagnosis of vivax malaria can pose challenge when we are talking about the existing RFDTs and, or even asymptomatic cases. So, diagnosis both for vivax as well as of for J6PD deficiency. Both are important for, actually treating the vivax cases, including the radical cure. Thank you very much for that presentation. So let us now, we'll have the other questions later at the end of all presentations. So let's move to the clinical studies which have been done for single dose treatment of tafenoquine, and which include the safety, efficacy, and feasibility of using this treatment regimen. So over to Kamala to present the the results from the various clinical trials she has been leading. Kamala.
Thank you very much. Thank you very much, Nina, and thanks for having me, and thanks to the organizers. I'll jump right into, so Emily really beautifully showed the diagnostic challenges both on the vivax and the G6PD side. Once we have sorted them, then we can move on to treatment. And I just wanted to start with this slide showing both tafenoquine and high-dose primaquine, which are probably the two most exciting kind of new tools in the treatment space. And on the right-hand side, you see beautiful work from Marcus and many others in the licensing trials for tafenoquine, where tafenoquine was compared or benchmarked against low-dose primaquine. We know that, more recently, WHO has recommended the use of high-dose primaquine. And on the left-hand side, you see a curve from a trial where we looked at the efficacy of high-dose primaquine. And so both of those graphs are under ideal conditions in a beautifully controlled trial setting where every dose is supervised. So this can't get much better than this. But we know that reality often looks very, very different. And so going back to that right-hand slide, where we see that tafenoquine did approximately similar to low-dose primaquine, we know that in reality, particularly when we give primaquine over 14 days, that green curve moves much, much closer to the gray curve, which is the placebo where no primaquine was given. Just highlighting that in the comments there, people somehow don't see the slides, so I don't know if the technical team can have a look at those. So important there then to see that high-dose primaquine seems to be, like, again, under supervised conditions working much better. And the idea, of course, is that if we squeeze that high dose into 7 days, we hope that adherence is better than if we give it over 14 days. Next slide. And this is something we looked into in the EFFORT study. And so this is data that is available as preprint and currently under review. And the QR code on the right-hand side leads you to the preprint for those who want to dig a bit deeper. So this was a study that was conducted in 4 countries, Pakistan, Ethiopia, Cambodia, and in Indonesia and Sumatra, with 960 patients recruited. And you see the sample sizes for each of those countries in the box there. And we compared low-dose primaquine given over 14 days unsupervised to high-dose primaquine given over 7 days unsupervised and tafenoquine. Of course, this was still a study setting, but we really made sure that we are not having much interaction in this treatment period with patients, and not to interfere with, I guess, the natural adherence behavior. And so you can see that tafenoquine and high-dose primaquine did relatively similar here. And from the previous slide that I showed you, we would have expected high-dose primaquine, if fully supervised, to do better. So we certainly see that difference here when it comes to adherence, that it drops, and effectiveness is slightly different to efficacy. Next slide, please. And this is particular prominent when we look at some of the subgroup analysis. So this is the subgroup analysis from the Ethiopian data, where the large proportion of patients came from. And we see that this gap here is increasing even more. And really interesting, certainly, that a lot of the qualitative research that we have done in the Ethiopian setting particular suggests that pill burden seems to be one of the main barriers for high-dose primaquine. So if you think of, with high dose, we already double the dose that patients are taking. And if we squeeze that into 7 days, the daily dose becomes quite high. And Ethiopia, as an example, uses a 7.5 milligram primaquine formulation. Many other countries use 15 milligram, which makes it a bit easier. But so it's quite a handful of tablets to take over 7 days. And that's certainly what we've seen to be, one potential explanation of that that even within the 7 days, you might have those issues with adherence. Beautiful to see there are quite a few attendees from Ethiopia. So next slide, please. One of the benefits, obviously, of tafenoquine over high-dose primaquine is that reduced pill burden and that single dose. However, there are still some barriers, certainly. Tafenoquine at the moment is recommended to be used with chloroquine only, and that really excludes the use of tafenoquine for quite a few countries that use ACTs as first-line treatment for vivax malaria, either because of drug resistance to chloroquine or because of operational considerations. And this restriction is based on data that you see here from the INSPECTOR study, which was the first study that looked into tafenoquine with an ACT, and in this case, DHA piperacin, which is the first-line treatment used in Indonesia. And you can see the results are quite disappointing, I guess. You see that tafenoquine here in blue has almost no efficacy when combined with DHA piperacin in the study, so very similar to the gray curve, which is the placebo or no radical cure. I'd like to highlight that the low-dose primaquine as the comparator here also had a very low efficacy with only 50% in this setting. In Papua, Indonesia, which is a very high endemic area with a very high disease incidence and a high hypnoside burden. Next slide. So this study led to a label change, as I mentioned, that tafenoquine can currently only be used with chloroquine. Next slide. Data from the EFFORT study certainly challenges this a bit. So as you remember from an earlier slide, within EFFORT, we recruited patients in Cambodia and Indonesia, in addition to those in Pakistan and Ethiopia. And in Cambodia, we used artesunate pyrineridine, or Pyramax, as the blood chasontocidal or blood stage treatment, and in Indonesia and Sumatra, DHA piperacin. And I'll start on the left-hand side with the Cambodian data, which really, if you look at the curve, looks very similar to the overall curve that I showed you earlier, where high-dose primaquine and tafenoquine, when unsupervised, tafenoquine and high-dose primaquine work very similar. They're certainly suggesting that tafenoquine in combination with artesunate pyrineridine seems to be working well. Of course, there are fairly wide confidence intervals here. If we look at the right-hand side of the slide, in Indonesia, it looks a bit different. So we see that both the low-dose and the high-dose primaquine work really well in this low endemic setting. And we have a risk of recurrence of around 22% with tafenoquine DHA piperacin combination. So this data is really very difficult to interpret because it's a small sample size and the curves certainly look different to the other curves. Next slide. But I'll try and make a bit of an attempt on how we can potentially interpret this data. So on the left-hand side, you see the INSPECTOR data again, and then on the right top side, you see the EFFORT data from Indonesia, just shown as a relapse-free probability rather than a risk of recurrence curve. So we just flipped the curve to make it a bit easier. And so if you compare them directly, it looks like it's much, much better in the EFFORT data in Sumatra compared to the INSPECTOR data on the left-hand side. But of course, we have a very, very different background risk here. So only because it's Indonesia doesn't mean it's exactly the same. Papua has this very high background risk and burden, whereas Sumatra has a much lower endemicity. Unfortunately, we don't have that gray line with the control arm in EFFORT, so we don't quite know what the background risk is. And we have to use historical data that you see on the bottom there to look at what the background risk might be. And apologies for a slightly different colors here, but here we have the control arm, the placebo arm in green. And you see at 6 months, this is about the same that what we see with tafenoquine and DHA piperacin, suggesting that there is hardly any effect. But if you look at the shape of the curves, this tells a little bit different story. So in INSPECTOR, you see very, very early relapses before month 4 that we think are more likely actual relapses, whereas those later recurrences that we see after month 4 in EFFORT are much more likely to be new infections. And that's certainly in line with what we see from the molecular data. suggesting that there might be some hope for tafenoquine and DHA piperacin. Overall, I think both the data from, certainly the data from Cambodia and in combination with the data from Indonesia, this really has opened the door to explore tafenoquine in combination with ACTs a bit more. And it's quite exciting to see that there are a lot of initiatives, a lot of new studies that have started already that explore that further, and more work planned to really get a better understanding, how much we can expand the use of tafenoquine potentially to different ACTs. I'll leave it here and hand back over to you, Nina.
Thank you, Kamala. I mean, we can realize from these studies, you have tried to capture every aspect of this radical cure. As such, there's so many issues, the total dose of primaquine, the duration of treatment, the compliance issues, and now, of course, we have single dose treatment, but whether we can use it with ACT, I think some studies, have been done with AL, but we can do that in the discussion. But yes, ACTs are being used in countries, even for vivax malaria, so we need to know whether these two can be combined. But as such, what I feel is that when patient is sick, it's easier to treat a patient, but the compliance is better. But the moment the patient doesn't have fever, and what happens for this anti-relapse treatment, the compliance is very poor, and that's why we need to take care with the single dose treatment and these new tools. And of course, the safety aspect is another issue. So it's really a complex thing to manage vivax malaria in the present scenario. Of course, all these issues have been addressed very nicely in the many clinical trials, and some of them which Kamala you have presented. Thank you so much, and we'll again go into questions at the end of presentations. So now I would request Dr. Marcus, your institution, the Tropical Medical Foundation, and with Medicines for Malaria Venture, they have conducted really nice real-world studies of deploying G6PD testing and single-dose tafenoquine, and that too through the public health system. And this work, of course, led to Brazil being the first endemic country to incorporate these tools in the National Malaria Program, which is a big achievement. And so from your experience as the principal investigator of these studies and the key person behind the study, and of course, public health specialist, what are the key lessons learned in moving from the feasibility studies and, efficacy studies to the scale up at national level? Over to you, Dr. Marcus.
Well, thanks, Nina and Pat, for the very kind invitation. I will give a very brief overview of the history of G6PD and use of aminoglycanolysis in Brazil. Almost 30 years ago, we have decided to move from the 14-day regimen to the 7-day regimen of low-dose primaquine, and that was when we started to see cases of hemolysis in our hospitals. So clearly, the daily dose triggered hemolysis in patients who were G6PD deficient at the time. So the first thing we did was to standardize the brewer's test, which is something very cheap that we can do in-house in our lab. And that was used firstly to diagnose those who had hemolysis due to primaquine. Then when I've been with Gonzalo once to Thailand, in the border with Myanmar, we have seen that they were using routinely the spot test to diagnose G6PD before the prescription of primaquine. So we actually started afterwards to use the qualitative care start test in our hospital. And the idea was actually to estimate the percentage of G6PD deficiency. So our researcher, Marcelo Brito, did his PhD on that, showing that 5% of the population in Manaus were deficient for G6PD. After that, MMV and GSK co-developed the first clinical trials on tafenoquine, single dose for the radical cure. And because of the trials, we have implemented spectrophotometry, which is the gold standard for G6PD evaluation. And because of those trials, we were a lot concerned on how the screening of G6PD would be taken to the field. So that's why we have received a grant from the Bill and Melinda Gates Foundation at the time to develop SafePrim, which was the first time in Brazil in which we went to the field to implement a rapid diagnostic test for G6PD. We have started with the qualitative care start because we were focused on Primaquine at the time. And the thing that we've learned from that is that people could actually implement a G6PD screening before the prescription of Primaquine. The second part of that study, SafePrim, was the evaluation of the SD biosensor, which is a quantitative, because we were already thinking about the implementation of tafenoquine one day. And the results clearly showed that people were able to use that test routinely in their clinical practice. Well, after the trials were published and FDA has approved tafenoquine for the radical cure, we have also registered that drug in Brazil. I think it was one of the first countries in the world to implement, to recommend tafenoquine. And so MMV played a major role in funding the first real-life implementation of not only tafenoquine, but also the G6PD test. So what's more challenging here is that you're not implementing only one drug, you're implementing a test which is performed before the prescription of that drug. We actually have been telling the Ministry of Health that even for Primaquine, we needed to use some type of G6PD screening, but since Brazil was using Primaquine without screening for G6PD for a long time, that did not call their attention. But because of tafenoquine, the new drug, which could not be withdrawn in the event of a hemolytic case, so we had to implement the quantitative G6PD test, and that was the SD biosensor that we had already the experience from the field that it worked nicely. So TRUST study was funded by MMV, and after TRUST was finished, we have treated 2,000 people, more than 2,000 people with tafenoquine. Those were essentially adults. And even in those in which a G6PD test showed that they were deficient and by mistake they have used tafenoquine, we did not see severe hemolysis. But this is the African type of G6PD. So keep in mind that things that are seen in one country, they cannot be automatically replicated to another country because the type of deficiency changes from country to country. In the Americas, it's essentially the same African type that you see in Africa. QualiTrust was a side study performed with Trust that showed that people received very well, not only the patients, but also the health workers that were dealing with the test. And it called our attention that they were seeing that less relapses were seen when they used tafenoquine, the single dose. And that replicated in the quantitative analysis, showing that when you compare the 7-day non-supervised Primaquine with tafenoquine single dose, you clearly see a benefit in the real life scenario that tafenoquine does better in terms of effectiveness. We had calculated the cost effectiveness of using the test, which is actually the most expensive part of the implementation of tafenoquine, and that showed clearly that it was of benefit to implement the test. So the Ministry of Health recommended, after TRUST study, to use tafenoquine in the whole country. So we are talking about hundreds of municipalities where malaria is endemic. And because of that, we have started since the beginning of last year, this implementation in many municipalities. Nowadays, most of the more endemic municipalities are already using tafenoquine. That includes indigenous areas, mining areas, and until yesterday, more than 17,000 cases were treated with tafenoquine nicely and safely. We are hoping to get started now with the pediatric tafenoquine, which hopefully will be implemented soon in the beginning of next year. So I think it's definitely a case of success, multiple partners, not only researchers, Ministry of Health, but also PATH MMV, and GSK. So thanks for the support of all of them. Thank you.
Thank you, Marcus. I mean, when at country level in the national program, these things can be true. That is the real test of the product. I mean, they are being used in the program. The one thing you pointed out, like many times there is a question. I mean, what is the need of testing? I mean, programs or countries have been using Primaquine, so many times question comes, where is the need to test? We don't see that many, people with hemolysis or the deaths due to Primaquine. But the question is that when it is a 7-day and 14-day treatment, we don't even know whether the I mean, so-called the no adverse effects reporting could be because there is no compliance. And then if we are using higher dose, shorter regimens and tafenoquine, definitely there is a need of the test, and a test which quantitative test which can be used at point of care, nothing like it. So this is another issue which when we introduce this single dose cure, that we need to convince the national program that the need for G6PD testing has always been there. And whether it is now single dose cure or when we use Primaquine for, I mean, the higher total dose for, good efficacy. So these such studies really set an example, and they can be, useful for other countries as well. Uh, so definitely, I mean, really very good results, and we can discuss further if there are any questions on this at the end of the all presentations. Thank you, Marcus, once again. So now, so we have Peter with us. Of course, now we have the emerging evidence and, new tools, and WHO always, when the guidelines are framed, there is a process. Of course, then I don't want to go into detail, but definitely the evidence is what they look for. And if it is the evidence for a new tool or a new test, those are incorporated in the guidelines. So, Peter, would you like to just give update? I mean, recently guidelines have been revised even for the radical cure. So, could you update us and everyone that how these guidelines now they align with what we have discussed today, and what in near future, considering the use with ACT and other aspects, which still we are struggling with, how do you plan to give guidance to the countries on these aspects? Over to you, Peter.
Yeah, thank you, Nina, and thank you for inviting me to be part of this discussion, which I think is very important. I just listening to others, I just wanted to re-emphasize again that the treatment for vivax, it's both the blood stage and anti-relapse treatment. So the issue have never been, should we use anti-relapse treatment? It is how do we safely administer anti-relapse treatment? So it's an integral part and a key part of treatment. And also to add that we're glad that we have tafenoquine now. Tafenoquine is not a complete replacement for Primaquine. It's an additional tool that can be deployed along with Primaquine, depending on the situations, depending on the circumstances, for anti-relapse treatment. So the whole issue of compliance with Primaquine remains an important issue that must always be discussed. But WHO, we use evidence that has been generated, a lot that has been spoken about today, to develop guidelines. We don't just look at safety and efficacy, but so many other things, including feasibility, acceptability, cost effectiveness, like what Marcus referred to a short while ago, implementability, equity, gender. So a lot of things come into making these recommendations, of course, hinged on efficacy and safety. And we follow a very strict method. All evidence is collated. You have a systematic review, or in some cases, we do the independent patient data meta-analysis, depending on which is more appropriate. A grade method is used and eventually leads to recommendations. And beyond this, we support countries to take WHO recommendations to formulate national policies, because it's the national policies that countries are implementing, not the WHO recommendations. a lot of local things, local factors coming into freezing those policies to fit into what is applicable and feasible at country level. And so it was in 2024, tafenoquine was recommended as an option that could be used in specific situations, though it was targeting mainly South America, but it's on board. I think one of the very key things these guideline processes helps to generate is one, identify gaps, both in terms of limitations to the recommendation, in terms of additional evidence required to better streamline the recommendations to expand the recommendations. So particularly for tafenoquine, like I said, in the guideline, right now it says targeting South America because that's where most of the data came from. And like Kamala indicated earlier on, most of the trials were looking at the low dose primaquine. So we are eagerly hoping and waiting and looking at the research community and to programs that are deploying even as part of operational research to generate the needed evidence to help one, streamline the recommendation, expand the recommendation, look at issues around the use with ACTs and in other regions and other parts of the world. So certainly evidence generation, the research, the implementation, and I must emphasize here one thing that was peculiar with tafenoquine or anti-relapse treatment was a lot of evidence was generated just beyond efficacy and safety. It was systematically looking at feasibility. How do you integrate the tests? Bring like Brazil, what Marcus talked about, where they're not doing tests initially. How do you safely deploy these tests? How do you ensure that health workers are trained and all of that? And those are very key and important things that need to be looked into just beyond efficacy and safety that to really help to strengthen and make recommendations. So we certainly see the PAVE and everything around the vivax as a very great way of moving things forward, looking at all ramification of evidence. And I will just end by saying, right now in WHO, in the malaria program, we operate what we call the living guidelines. So we don't wait for 5 years before we update. Once evidence becomes available, even in specific areas, we have the ability to update the guidelines. So we're looking expectantly to the issues around ACT, tafenoquine, and high dose primaquine. And once we have those evidence available, we would, as it were, instigate or start the whole process of updating the guidelines. So I'll stop there to give room for questions. I don't want to go into details on the guideline process, but this is essentially what we do and provide. So and I also say that we are encouraging countries outside of South America to also do what we call phased or guided implementation, where they collect data to help expand this recommendation beyond South America. Thank you, and we'll take questions as they arise.
Thank you, Peter. To some extent, I have been part of this process of guideline, and I know, I mean, always we say it is a guideline, and of course, the ultimate responsibility or decision depends on the countries, and there are so many other factors, not only the, whether it is efficacy or not, how can they access, how and which till what level of healthcare those things can be used, and how safely we can use. So there are so many aspects which, WHO guideline do consider, and which is not easy, of course. And, I believe that in near future, of course, use of tafenoquine with ACT, and there will be many other aspects which need to be looked into, and the evidence will help in framing the guidelines. So Peter, since we are discussing with you, and there are some questions, I think they are they can best be directed to you, although I think they are easy ones. So one is the current regimens for drug-resistant vivax malaria, and there are, of course, diagnostic. I can refer to other speakers, and then very easy one: can tafenoquine be used to treat P. falciparum? So over to you, Peter, on this.
Yeah, well, I start with the last one. Right now, there's no recommendation to use tafenoquine for treatment of falciparum malaria. I think the question was actually maybe, can you use tafenoquine the way we use primaquine as anti-gametocidal, but there's no recommendation in that regard yet. So it's just strictly for anti-relapse treatment for vivax. In terms of resistance, the protocol, well, like we have in the guideline, for a very long time, what was used was chloroquine for vivax malaria. And there's a recommendation that any of the ACTs can be used in areas where you have chloroquine resistance and that's why it's important that we actually also look at the issue around tafenoquine and the ACTs. Otherwise, that is a limitation again to areas where it can be used. So that's a very key point and factor that needs to be looked into. Yeah, I think those were the two questions that I had.
Yeah. Yeah, thanks, Peter. I said easy ones. And moreover, if even the lower dose, I mean, such a low dose of primaquine can be used for falciparum gametocytocidal activity, where is the need of, using a medicine which is long acting. So that's very logical. And so maybe, Emily, can I ask you, I mean, there is a question on how are diagnostic tests calibrated to ensure accuracy?
Yeah, thanks. So as I mentioned, there's one WHO pre-qualified test for G6PD deficiency at the point of care and others in the pipeline. The ones that we have seen so far all have external quality controls that can be used at the point of care to ensure that the test is working as expected. And I think what we've observed during some of these studies that Dr. Marcus mentioned and Professor Kamala mentioned is that, in various settings, a combination of those external quality controls with kind of internal procedures can be used, internal procedures such as training, proficiency panels, et cetera, can be used to really monitor the test results and flag when there may be issues. Yeah, I don't know if anyone whose field teams have had experience with the test would like to comment on that. But yeah, there are external quality controls available for the test that we've seen.
Excellent. I mean, any of other panelists would like to add to this comment, or we can take other questions?
I think that the machine works very well. Surprisingly, over time, it's very consistent, very accurate. We have retested people who were shown to be deficient or intermediates, and it replicates very well. I think the question of training people is more critical. So you will need in the first time to train and retrain people specifically because of the dilution, the way they collect the blood. It could be something critical, but nothing more difficult than reading a thick blood film. So keep in mind that thick blood smears, they're much more complicated to read than to perform a G6PD testing.
Thanks, Marcus. So I can see another question, which is, of course, relevant from, when we implement something in the national programs. I mean, somebody has mentioned that when using tafenoquine, do you notice drop in hemoglobin? And even if it is not severe, patients are anemic, and even with malaria, of course, the hemoglobin goes down a little bit for initial 2-3 days. So should hemoglobin be tested before tafenoquine? And I know this device, it gives a value for hemoglobin as well, but what would you like to add to, respond? How would you like to respond, Kamala, to this question? Maybe Marcus can add if he likes.
Yeah, I can make a start. I'm sure Marcus can add. So in the trials, we didn't see any drops, but we have, because it is a clinical trial, very strict inclusion and exclusion criteria. So apart from G6PD, which obviously had to be normal, we only recruited patients above a certain threshold of 8 gram per HB, which, in reality, probably excludes quite a few patients. And so in that cohort, we certainly didn't see these drops. And I'm sure, Marcus, you can comment further on how that is reflected in your studies and in your more routine use.
Yeah, we don't see any drop in hemoglobin after the use of primaquine and tafenoquine, unless they are just G6PD deficient. So if they're not deficient, the trials clearly show, using a comparator with chloroquine only, that the drop in hemoglobin is much more linked to malaria itself than to the use of aminoclinolines. So from all the trials that we have seen, using primaquine or tafenoquine in someone who's not deficient will not lead to any hemoglobin drop because of the drug, but because of malaria itself.
No, I mean, one part is true that in these endemic countries, people are, anemic. And so of course, malaria causes decrease in hemoglobin, but do you think at below certain level, it would be not safe to use these if there is a hemoglobin level below a certain threshold? I mean, beside when it goes to for use in the national programs. Of course, in the trials, it is much more regulated. And we have our device also gives, hemoglobin levels so that we include or exclude the patients.
I think
Do you
we
see
can,
any
we have,
challenge?
yeah, I think we have a clear limitation to use tafenoquine in those who are severely anemic, because the test cannot be reliable if there is a hemoglobin which is very low. So in that case, the device will give you something which is not valid. So when the hemoglobin is very low, it's not valid, the G6PD test value. So in that case, that person will not be submitted to the use of tafenoquine. So to some extent, the device gives you already a certain limit of hemoglobin in which you can rely on the G6PD testing value.
Yes, so that is an important point, and which needs to be taken care of when we are talking about this. Yeah.
And
So
just to clarify, I think that
please.
threshold for which the result is recommended to not be used is 7 grams per deciliter, with tracks with a lot of clinical guidance that countries have around not treating people with radical cure below that threshold anyways. I think could be a possibility to treat someone after their hemoglobin level recovers if it is really malaria-induced anemia. But yeah.
Thanks. Peter, so how do you think, I mean, of course, now all depends on more data, availability of more data and other safety aspects, but taking the experience from Brazil and, other studies, how do you think WHO can engage more effectively with the regions or countries, and especially because there is another aspect of, not only efficacy, as we mentioned, the access to these tools, and how can more engagement be there with especially the vivax endemic countries? Peter?
Yeah, well, like I said earlier, part of the recommendation, we actually have encouraged countries to do controlled deploy studies, well, controlled implementation. Well, I call it that way. That has varied interpretation, but in essence, what we're saying that if you're deploying in those areas, it will be, we expect you to collect some basic information that would help towards it, because essentially tafenoquine introduction is based on comparative efficacy to primaquine. So essentially it was not tafenoquine versus nothing, it was tafenoquine versus primaquine. So it was like equivalence. And so because of the single dose of tafenoquine, that gives you the advantage in terms of effectiveness. So yes, we're encouraging countries, even the Global Fund, this I can say, in some of the materials they are putting together towards the next round include some statements there encouraging countries. We've had some countries who have asked directly. They've had it in their guideline. Should they procure this drug? Say, yes, you can, but these are some of the things we expect you to do. So yes, there's the active engagement. And of course, on the side, we also continue to engage with the key researchers, some of them who are on this call, say what and how fast can we move things to update this recommendation. Thank you.
Thank you, Peter. And of course, we are nearing the end of webinar, but there is an interesting question. I mean, the pace of diagnostic discovery is slow, and also the marketing is slow. What steps could be taken to speed it up? I don't know. Who can volunteer to answer? I don't know if we have a specific answer to this, but any comments from anyone? Okay.
I
Yeah.
I think it's a valid point. I know it's something, you know, at the diagnostics program here at Path, we talk a lot about and really just try and cultivate that ecosystem where both, you know, demand and supply kind of reach. But I think it's a well-noted point. There was one additional question around the serological test being used with tafenoquine.
Right. Yeah, please go ahead.
Yeah, and I was just going to comment. I think it's really interesting. You know, would also be keen to hear if the panelists have other views, but I think it's a very promising combination because you're really taking this test to the field to identify people who are potentially not, you know, sort of actively experiencing symptoms. And so I think that's where some of those challenges with adherence to a long treatment regimen would really kind of come into effect. And so if you think about all the investment that a program would have to make into using the serological test and sending teams to the field and identifying people, I think having that single dose treatment would really sort of make good on that investment rather than leaving people with 2 weeks of pills and hoping that they take it. So yeah, I think that's an interesting sort of new area for exploration.
Definitely, that's a very valid point. Yeah. And there is question related to affordability, but I think that those are different issues which can be discussed. So thank you all for joining today's this deep dive into the evolving landscape of vivax malaria treatment. Of course, we have new tools and new diagnostics, and this may and should, I mean, reshape the malaria elimination efforts. But, you know, in addition to having the tools or having new tools with us, there is a lot more when we talk about the access, availability, affordability, and then the partnership is needed, like between researcher, policy makers. We have good examples like in Brazil, but then frontline health workers, the feasibility of using these tools. So there's so many other aspects to it rather than just having a good tool also. And then, of course, convincing the national programs to use it and use it safely and implement it safely. So I'm sure that everybody must have got a very good, valuable insight from this expert panel today. And on behalf of the organizing team, thank you for all of you for your engagement, your questions, and thanks to experts for sharing all their experiences. And also, you know, this shows the commitment to ending vivax malaria. And let's keep this momentum going. Thank you, one and all, once again. Thank you.
Thank you. Bye-bye.
Bye.